Hello, and welcome to TEDMED's live event focusing on great challenges. The great challenge we're talking about today is addressing healthcare costs and payment systems. My name is Kavita Patel, and I'm a physician and a managing director and fellow at the Brookings Institution, and I'll be moderating today's discussion, which will last for about an hour. This session is part of the Great Challenges program, generously supported by the Robert Wood Johnson Foundation, so I wanted to acknowledge their support of this. The goal of the Great Challenges program is to look at 20 of the most complex problems in healthcare and in medicine, issues which can't be solved with one magic bullet, and have a great deal of ideas from a number of disciplines and a lot of people from different backgrounds that can give us their expertise. So our goal is to reach a better understanding than we had before, and not to just offer a one-shot cure or policy solution, because we all know it's much more complicated than that, but if we draw from the ideas of those around us, we know we can get there. We'll be taking questions from viewers on Google Hangouts, Facebook, and Twitter. Twitter's hashtag Great Challenges @TEDMED. So use the hashtag and make sure you use the handle @TEDMED, TEDMED, and just tag your questions with the hashtag Great Challenges, as I mentioned, so that we can try to get to them. And that's exactly what we're going to do this hour. I gave you a little bit of my background. I'm a practicing primary care physician, and previously to my current role at Brookings, spent time in healthcare policy on the Senate and in the White House working on health reform. But we are delighted to be joined by an extremely accomplished team of experts whom you'll be able to see and interact with. And let me just start by briefly introducing them. First, we have Jeannie Pinder. She's the founder of ClearHealthcareCosts.com, which is bringing transparency to the healthcare marketplace by revealing healthcare prices. As a longtime journalist, she believes that transparency is an overwhelming good, and the healthcare marketplace transformation toward patient empowerment, participatory medicine, can only work to benefit providers, patients, and all participants. Welcome, Jeannie.
Thank you.
Next, we have Ron Pollock. He's the founding executive director of Families USA, the national organization for healthcare consumers. For 30 years, Families USA's mission has been the achievement of high-quality, affordable health care coverage for everyone in the United States. Welcome, Ron.
Good to be with you again, Kavita.
And next, we have Jeannie Stamper, who is a program director for Xerox Services, where she leads key initiatives with health insurance clients related to healthcare reform. At present, her work is exploring how technology and process innovation, for example, managing patient interactions, leveraging analytics, and multimodal communications, can positively impact healthcare costs. Welcome, Jeannie.
Hello.
Next, we have Ann Gauthier. She's a senior program director at the National Academy for State Health Policy, where she manages a portfolio of projects on state roles in health reform and health system performance. Currently, she directs the State Health Exchange Leadership Network, which is a peer-to-peer learning community for state officials working on health benefit exchange development, sponsored by the Nathan Cummings Foundation. Welcome, Ann.
Very nice to be here.
And last but definitely not least, we have Chapin White, senior health researcher at the Center for Studying Health System Change, he is focused on microsimulation modeling of health reform, long-term trends, and geographic variation in healthcare spending, medical malpractice, nonprofit hospitals, and Medicare payment policy. At HSC, he is focusing on policy analyses related to the implementation of healthcare reform and original research such as related to that. Welcome, Chapin.
Thanks, Kavita. Hello, everyone.
All right, so let's get to it. Now that we've gotten some of the logistics out of the way, hopefully, again, I'll just mention using the hashtag Great Challenges in any of your comments, and on Google, Facebook, or Twitter at TEDMED. Let me just start with a statistic, and then let's get into some questions and discussion. In 1980, there are many of us on here who can remember the 80s fondly. In 1980, we had healthcare expenditures in the year 1980 of $256 billion. 2010, 30 years later, our healthcare expenditures were $2.6 trillion. Went up 10 times that in a span of 30 years. And while our healthcare costs have been slowing down over the last couple of years, there's still a great deal of concern about the amount of money we spend in healthcare, and then I think even more importantly, how sometimes those costs get shifted and passed on to patients, us, in the form of rising health insurance premiums and rising costs when we try to get our medicines and go to the doctor. So we do have an all-star panel of folks who have a great deal of expertise, and we have been getting questions on social media, as I mentioned. So I'd like to just go ahead and kick it off with asking a question and let the discussion go from there. So first we have a question from Facebook user Joshua Daniel DeGastine. Pardon me if I get the name wrong. Would our national, and this is a question for Chapin, so Chapin and anyone else, we'll see if there's some other panelists that might want to weigh in on this, but briefly, Chapin, here's the question Joshua asked. Would our national program benefit from standardization of doctors' annual salaries? So I think what Josh was trying to get at is, could we use some standardization for the reimbursement to doctors for their services instead of our fee-for-service reimbursement?
Well, it sounds like there are really two questions. One is, would we benefit from moving away from fee-for-service medicine to a system where physicians are all paid salaries? And then the second question is, would we benefit from some sort of overall reduction or some selective reduction in the salaries that certain types of physicians receive? And I mean, I think bringing physicians' salaries down would certainly reduce healthcare spending, slow healthcare spending growth. Physician salaries are actually a pretty small slice of the overall spending pie, but I think the fact that physician salaries are high in the U.S. is indicative of a general orientation we have in this country that's generous toward medical providers and generous toward insurers and the other players in the medical field. And I'll leave it at that. Okay,
great. Any other reactions from our other panelists?
This is Jeannie Stamper, and I would add, and I'm not seeing the video show my picture, but I would add, you know, if you're thinking at it from a physician's perspective, you're missing looking at the larger provider community, which includes hospitals and more than just physicians. So, and we see the trend now where a lot of physicians are giving up their private practices and going to work for these larger organizations, and we're seeing the merging of provider organizations with payer organizations. So there's a lot of change in the landscape right now around who's getting paid.
Great.
I'd like to jump in if I could, Kavita.
Yes.
I'd like to focus here on the aspect of moving away from the fee-for-service system. In a fee-for-service system, providers, physicians, or other providers get paid for providing a service, and they have a great incentive to continue to provide more services, whether or not they are effective or of high quality or necessarily useful for the patients receiving them. This is not to say that physicians want to give unnecessary treatment, but in our fragmented system that we have now, where test results can be lost because there's no communication between providers, physicians may have an incentive to repeat tests or to get their own information because it is not in one central place. So we could go a long way in changing the payment system that would help provide a more coordinated system, and that's a real goal.
Absolutely. So, and I'll just conclude that thought by saying that from when I went to medical school to now, the majority of students are actually excited and are seeking out salaried options and want to not be in what they consider kind of this perverse incentive volume-based reimbursement modality. So it reinforces what each of you have said. All right, we have another question. It's buzzing, and this is from Elin Silvius. Again, apologies if I mispronounced your name. I'd love to direct this first to Jeannie Pinder first, if you don't mind, Jeannie. So you're on deck. Can you give us some clear examples of effective strategies for containing healthcare costs that you've seen? Maybe even as specific as you can be based on what you're seeing from the work you're doing right now on your website. their healthcare costs?
Thanks. That's a great question. Yeah, we are seeing actually patient consumers, I choose those words very carefully, using the information that we've supplied about actual prices for actual procedures to make decisions. If you are uninsured and you need a blood test, and you can get it for $16 or $117, the same procedure, we've given you some very concrete, actionable information. By the way, that one small example reduces our national healthcare spend and sets an example for others. So we're seeing people who really are interested in those prices.
Okay, great. Ron, are you seeing some examples in communities and some of the work that Families is doing?
Well, I would agree with what Jean said a moment ago. You know, it really is helpful to have transparency in pricing. We find that they're very different prices depending on who the payers are, and it would be good to have that much clearer. And you know, I think we need to, building off on what Ann said to the previous question, we've really got to make sure that physicians as well as patients have a much better understanding of which clinical services are going to provide greatest value and are going to really be much more effective in terms of clinical outcomes. And unfortunately, we do not yet have enough research. That has to continue to be encouraged, and that research needs to be disseminated to physicians and to patients so that patients can share in the decision-making process. So I think each of those things are components of what we need to do to get costs down.
Great. And there are a couple of, I just want to point out for some of our viewers and listeners, there are some really interesting examples in communities. For example, in Cincinnati, there's an effort throughout the entire city to work with providers as they're ordering tests to show them how much a test might cost, and in many cases what their insurance for the patient that they're seeing might not cover at the point of service through the electronic health record. That's one example. We also have a lot of examples around what we've been calling shared decision making, so that when a doctor who wants to engage, a doctor or any other provider who wants to engage in a very practical discussion has a set of tools to talk about with their patients, because one thing I feel as a doctor is that we get uncomfortable talking about cost, but we need to have better tools to understand how to give patients more choices. So I'll point to some of those very specific examples throughout the conversation to help.
You know, Kavita, that I think our culture, at least for quite a long time, has been, we don't talk about costs.
Right.
You know, doctor says, this is what I suggest you receive in terms of care, and that's it. Yeah. There's no questioning about the efficacy of the treatment. There's no question about what the costs are going to be. And we've got to improve consciousness about what works and what the costs are. And that really is a total change in culture.
Let me pick up on another aspect of culture. I think that we are deeply acculturated to more is better. More medical care is necessarily better. And those who have studied this know that that is not true, that at least a third of care provided is potentially unnecessary and even potentially harmful. So we need to have a better way to have patients understand that getting all the tests, getting treated is not always the best course. Getting antibiotics for a cold, for example, is something that is totally against what is good for the patient or good for the population.
Absolutely. That's a great segue to our next question that came from Patty Kobluski, and she's asking, what can patients do specifically to help reduce costs? So I'd love to actually start. Jeannie Pinder, do you have some tactical recommendations for patients who want to reduce cost? And then I'd like to follow that up with Jeannie Stamper to also see if you've got any advice for our questioner.
You know, we noticed that people who are millennials who tend to be uninsured, for example, are happy to do shopping for healthcare on this device, that when we find that about a third of our traffic comes from the handhelds, that people are actually going to this and shopping. They may be people who directly have skin in the game because they're uninsured, or they have a higher deductible, or they have a percentage. But I think those people in their 20s and 30s, having skin in the game, having the skill and the tools to shop with this thing, are really going to change the game for everybody. They're showing us the way every day. I talked to somebody yesterday who actually rejected 2 tests that her doctor offered because he felt they would be covered. She wasn't sure. She didn't think she needed them. We hear this all the time, and it is a huge culture change.
So having the ability to use decision aids like
Right.
what you can get on an iPhone and apps
Right.
that might help facilitate that,
Right.
that can be a real effective tool patients should use. And it sounds like some of you might have some ideas on how to direct patients, because it can be pretty overwhelming to just get on the internet sometimes. So that's very helpful. Jeannie Stamper, any other comments about specific examples that patients themselves can initiate to help reduce cost?
Well, I think that the Jeannie Pender brought up the demographic issue, and that's not only age related, but it's more socioeconomic related as well. Where and I think Kavita had I read the interview that you had done when you agreed to jury this panel, where you had said we really need to get some sort of informal spokesman. I think you had joked we needed Dr. Oz or an Oprah to really help the public understand what kind of power they do have, and to start to educate them about how to know what the options are and how to participate as in the decisions around their care. So,
Kavita, I'd like to just add two
Sure.
quick comments.
And I wanted to pull you in, Anne, with a question, and go ahead.
So, it's common thinking to feel that, as the expression goes, you have skin in the game. You're going to be much more concerned about costs, and of course, there's a lot of truth to that. One caution I have about that is there are a lot of folks who are in very difficult socioeconomic circumstances, and we've got to be really careful about what we mean by skin in the game. A high deductible for somebody in a moderate income situation could really mean they're not going to get health care at all, and so we have to worry about that. But to the extent that there is skin in the game, I think it is fair for us to think a little bit more about tiered pricing for services, so that it encourages people to get the clinical services that are going to be most effective. Now, for that to work, however, patients have got to understand what the outcomes are likely to be under different kinds of clinical approaches to a health problem. So we not only have to broadly disseminate the research that is taking place to physicians, we've got to make sure that it's in the hand of patients as well, so they can make thoughtful decisions.
Great point, Ron. Anne, I wanted to ask you, there have been a number of Facebook users and others who have all kind of been wondering about how the new state health insurance exchanges might play a role in decreasing cost, or at least having some transparency. We often describe the exchanges as the Amazon.com or kind of the marketplace for buying health care. What are you seeing, Anne, and can you give us any examples that of states that are taking particular efforts to try to bring some cost transparency to the consumer market?
Well, you've thrown me a great question, Kavita, so thank you for that. As we say at Nashville, if you've seen one state, you've seen one state. That said, there are 18 states and the District of Columbia that have begun the path of developing their own state-based exchanges. There will probably be about 7 others that will do so in partnership with the federal government, and the rest at this time will default to a federally facilitated exchange. Now, for those states who are in state-based exchanges, one of the key decisions they had to make, or they are continuing to make, is whether they want to use the market power that they will have to try to affect changes in the marketplace, that is to improve quality and to potentially decrease costs. So, for example, they have the opportunity to set standards for qualified health plans that do the minimum in the Affordable Care Act, but that also potentially participate in payment reform pilots or other types of delivery system reforms. And in showing those options to the state's consumers, the state exchanges have the opportunity to, if you will, give those health plans a gold star and help consumers understand that they will in fact get a better value. There are at least a number of states, California is one of them, that have said that we want to take an active role in making sure that the best health plans and the most cost-effective and highest quality ones are available for our state's consumers. And their state exchanges are in a process to determine what those standards are. I think that as exchanges are up and running, as more consumers have health coverage, so many more Americans will be covered when the Affordable Care Act is fully implemented. I think there will be a great opportunity for exchanges to influence in a very positive way, rewarding health plans that take on some of the key reforms that are going to help us get to better, affordable, quality care.
Good. So it sounds like not only do you have a great point, Anne, but thank you, because it sounds like there's so much excitement and energy in this area that we'll hopefully be able to deliver on this notion that through these exchanges and I certainly understand it's going to be probably a little rocky at first. My experience has been in Massachusetts, where now they've had a number of years, but I'm excited and looking forward to what you're talking about. So thank you. Chapin, I'm going to direct this next question to you. Stacy on Twitter has been asking about the often cited geographical variation in the cost of care. Why are there such differences across the country in the cost of care? And what can we really do to kind of eliminate this gap in terms of cost?
Boy, that's a big question. Let me see if I can boil this down to a minute or less. So there's been a huge amount of research done on geographic variation in Medicare spending, and the reason for that focus is there's excellent data on Medicare enrollees and spending in the Medicare program. Outside of the Medicare program, it's been much more difficult to get data on healthcare spending. Although researchers are starting to get access to Medicaid data and data on the privately insured. This is all a long introduction to saying that the research findings, and Anne actually alluded to this in one of her comments, the research findings based on the Medicare spending data seems to indicate that higher spending areas have quality of care and outcomes that are no better and in some cases worse than low spending areas. As more research comes out, it looks more and more like that finding doesn't necessarily hold true for if you look at spending among the privately insured or if you look at spending on the entire population. So and it also looks like the reasons that spending are higher in one area than another are different for Medicare versus the rest of the healthcare system. So I think at this point. We know there's a lot of variation in spending. A lot of it's due to differences in prices and health status. It's not totally clear that our goal should be to bring all spending to some uniform, correct level. And I'm interested to hear what other people have to say on this.
Oh, I have an idea that I'd love to share and ask you guys about. I'm sure you all read the Atul Gawande piece in the New Yorker about the 2 towns in Texas that had widely varied spending. Everybody's smiling, so I know you all read it. I think his conclusion was, I forget, it was, I think, El Paso and San Antonio.
Yeah, I'm from Texas, El Paso and McAllen, Texas.
And McAllen, thank you.
And
So I went back and reread that again recently, and I was really struck by his conclusion, which was that essentially what he thought was the primary reason for the disparity was that there was no one single person entity who was responsible for controlling costs. That everybody felt that it was somebody else's job, or that I think there was one of the, whichever one was the more expensive one, that there was a culture of overcharging, and that everybody felt that was the sort of standard practice, and that there wasn't anything wrong with it. I think, you know, the lesson that I drew from that was that the system that we've established sort of deprives anybody and everybody of responsibility, and that being able to fix that, I think, is the thing that we're talking about here. So, you know, one of our solutions, of course, is to actually put the information and the responsibility, at least partially, in the hands of the patient consumers who don't have any information right now or ability to really affect the status quo. I wonder if anybody else has any thoughts about that piece.
I think there are a number of factors that are likely to result in geographical variations. We had a conference that Families USA puts on each year, and Elliot Fisher at Dartmouth spoke at the conference. And in some places, certain kind of procedures occur far more frequently. Now, this obviously doesn't, what I'm about to say, to the Medicare population, but the preponderance of cesarean deliveries is very different from one geographic area to another. There's difference in terms of how much coordinated care is taking place. You know, so much of healthcare costs in America's healthcare system for people who have chronic health problems, chronic disabilities, and those who have them tend to have multiple chronic conditions. And we don't have adequate coordinated care in some communities. We have better coordinated care in other communities. There's difference in the concentration of specialists in areas. That's a factor. So there are a number of factors that contribute to one community having considerably higher costs than another.
Great, thank you. Actually, Ron, just to stick with you for a moment, can you tell us, because some of what we're touching on is very different depending on our population's health literacy. Even though we have a great number of patients that are accessing information online, we still have sometimes a gap in internet access. And certainly as we look at patients who don't have English even as part of their regular language choice, as well as populations with limited social means, we are starting to understand that it's very complicated. And so as we sit and talk and chat a great deal about cost, you've highlighted at least the need to think about a lot of various different factors. Can you talk for a moment about how you are seeing the issue of cost be addressed in a more vulnerable population and what that means?
Well, a couple of things come to mind in response to your question. First of all, as you know, we have still tens of millions of people in the country who are uninsured, and unfortunately, they typically get charged higher prices for their care than people who are insured. And to go to the question about literacy, you know, a lot of people have access to these little devices and look at them. But I have to tell you that, you know, the understanding about different facets of our healthcare system are very different, often on socioeconomic grounds. Give you an example of this. This doesn't answer directly on the question of cost, but I think it highlights how significant there are information gaps. We just did a national survey of people who are or were uninsured. And these are people, as you know, Kavita, because of the fine work you and your colleagues did in putting together the Affordable Care Act. If anything, the Affordable Care Act is designed to make sure that people who don't have coverage or didn't have coverage are going to get it. The overwhelming majority of people who are or were uninsured simply don't have any idea about what the Affordable Care Act is going to provide to them. You know, whether it is new eligibility for the Medicaid program in a variety of states, or whether they can go into the marketplace, the exchanges, pick a plan and get tax credit subsidies. Over 3/4 of the people who are or were uninsured simply have no idea about that. So when you're asking folks actually to try to figure out what clinical care is best for them, what's the most, which provides the greatest value, there is an enormous gap, and the people who need this help the most often have the greatest problems with the written word. And so it is something that I think is going to cause real problems for different parts of the population.
I think of this sometimes, we talk a lot in like telecommunications about like the last mile, kind of that cable to your house connection. There is definitely a gap I see growing in healthcare, and especially with cost and how to take what we know and the Dartmouth Atlas and statistics and facts and Congressional Budget Office figures, and how do we really plug and connect that to where the rubber hits the road. So thank you, Ron. Well, as no surprise, social media is definitely keeping us busy. Omar Fernandez asked the question, and Jeannie Stamper, I'm going to see if you want to take this first and ask any panelists, where can telehealth fit into reducing costs? And certainly I know employers are looking at this and a number of other applications. Jeannie, any insights and specific examples that come to mind? Oh, Jeannie, you might have muted your line, so go ahead and unmute and we can start over.
There you go.
Great, we can hear you.
All right, I'd like to add a comment to the last discussion as well that I think is related. We were kind of focusing in really on the patient side of the equation, but as you look at the disparate costs across geographic areas, and you're looking to how do we move toward consistency, we should also consider the provider side where, if we move toward more evidence-based care and best practice protocols, that's going to help drive consistency and cost as well as the consistent outcomes. As far as telehealth and telemedicine and the ability to reduce costs, so absolutely, it's intuitive to say that using technology to reach people is going to be more cost efficient in many ways, and a lot of people are saying, oh well, we don't really have the technology in some of the rural areas, but there's been studies that have said that really the vast majority of the patient population is in areas that are served, and so we really need to escalate the use of telehealth and telemedicine, and we're seeing that happen today.
Absolutely. Any experiences from the rest of the panel on the topic of telemedicine or telehealth and reducing cost?
I'd like to talk about it. One thing I saw over the summer, I was in Alaska during a part of the summer, and I was watching a program that involves dental therapists. They're precious few dentists in Alaska, and particularly in low-income communities and some of the Native American villages. And so in Alaska, there's a significant program where dental therapists are providing significant care for people, and they are hooked up through telemedicine with dentists in other parts of Alaska or in Seattle. And so when they detect a significant problem, they can do real-time consultation with dentists in other parts of the country. And as we see a lack of adequate numbers of physicians in certain parts of the country, certainly primary care physicians could be hooked up with specialists in other parts of the country so that decent care can be provided, and a primary care physician can get counsel from a specialist who might not be in that particular community.
Great example, and a similar example in Washington State that's being led out of the University of Washington, but all across federally qualified health centers in the state of Washington, for telepsychiatry. So psychiatry is just very hard to find outside of Seattle, Washington, because of just, as you mentioned, Ron, shortage of providers. And so having the ability to connect community-based primary care physicians who are dealing with patients with mental health needs but don't have a psychiatrist for hundreds of miles, having them be able to connect with the primary care provider and offer consulting guidance and all of this through the internet has been making a huge difference for cost, as well as for diagnosing and treating mental illness in the state of Washington. So I wanted to point that out. So we've had also, I want to shift gears for a second. We've gotten pretty specific, and we've touched on the topic of patients, providers, other roles. We've mentioned the Affordable Care Act a number of times. There has been a lot of dialogue and somewhat controversy around what the Affordable Care Act is doing inside the law to help reduce costs. From my time in the White House, there was actually a great deal of debate as to whether health reform would end up costing the government and society more money, or if, as we hoped, some of the provisions therein could help reduce costs. Chapin, you've been researching this. I wanted to ask you, and then Anne, based on your work, can you give us a couple of examples or comments around how the Affordable Care Act is addressing the cost issue?
Okay, so I guess when I think about healthcare spending and costs, there are two major influences. There's the patient side or the demand side, and then there's the provider side, how much are providers getting paid. And the Affordable Care Act had two huge pieces. One related to expanding coverage through Medicaid and the exchanges, but the other major piece related to Medicare. And the Affordable Care Act permanently slowed the rate of growth in the prices that Medicare pays to hospitals and to skilled nursing facilities and to pretty much every provider type other than physicians. And when people talk about what the Affordable Care Act did, there's a lot of focus on accountable care organizations and bundled payments. But if you look at the dollars, and I was at the Congressional Budget Office during the debate over health reform. If you look at the dollars and what the Affordable Care Act did, what it did in Medicare was to reduce the prices that Medicare pays to providers, and economically, it's having and going to have huge effects. From 2012 to 2021. CBO is projecting that the savings to the federal government are going to be about $400 billion from reducing the growth in prices that Medicare pays. And from the work that I've done, it looks pretty clear to me that when you reduce Medicare prices, other private insurers pay less as well, and you also are going to see a slowing in the growth in the volume of services that people get. So the Affordable Care Act, to me, is going to be restraining spending growth, for the foreseeable future, and that slowing spending growth is one of the major impacts of the ACA, but that people mostly focus on the coverage side.
Right, great. Anne, any thoughts as well to add to that, to complement what Chapin?
Yes, absolutely. While there is the coverage side and there are the costs of the subsidies, I'll say one point there, but then I want to jump to delivery system reform. On the coverage side, one thing that's going to happen as more people get covered is there's going to be much less of a cost shift. So I think that's going to be a very important part of potential cost savings, although initially as people get covered, they're going to use more services. And we know that too. But let me jump to what I think is among the most exciting aspects, and there are a lot of them in the Affordable Care Act, and that is the opportunity to innovate in terms of payment reform. The Center for Medicare Medicaid Innovation within CMMI, or the Innovation Center, has significant funds that are being used not only for accountable care organizations, but an extremely exciting initiative is about to be announced where states who have many roles in affecting delivery reform are going to receive grants. that's going to be announced soon, either to plan for multi-payer payment reform, that's multi-payer, getting all the payers aligned around in a coordinated plan in order to pay for higher quality, lower cost care, or 5 or more states will actually be able to bring Medicare, the state as a purchaser, Medicaid, and private sector employers to the table to actually implement some of these exciting delivery models that hold promise, including not only medical homes for across payers, aligning measures and aligning strategies, but also accountable care organizations and other models that show promise to really slow the cost curve. I can't say give enough to how we don't actually know what works specifically. We're a big country. Healthcare delivery is local, and we need to try a number of things and measure their impact in rapid time so that we can quickly diffuse these innovations. And I think the Affordable Care Act provides a unique and unprecedented opportunity to do that.
Great. So let me shift gears and take another question from social media. And Ben Miller is asking on Twitter, how can we effectively tackle healthcare costs without addressing mental health issues? So we've had a lot of talk, we've had a lot of discussion as a country about mental health and gun policy over the last couple of months, but the issues of mental health have really been in a number of ways legally addressed through mental health parity laws and some extensions within the Affordable Care Act. But I think we would all agree on the panel there's much more work to be done. Maybe, Ron, I'll start with you to see, and then Jeannie Pinder, if you don't mind. But Ron, what do you think about when our questioner asks kind of what are we doing to deal with mental health and how that plays a role in cost?
Well, as you know, of the essential services set forth in the Affordable Care Act, mental health services is one of them, and we've got to move closer to real parity as opposed to rhetorical parity. Often there are limitations on how many visits you can have to a physician, and of course anybody who's got a mental health problem, it's probably going to exacerbate their physical health problems as well. Obviously, as more and more people have medical homes through Medicaid and Medicare, I think that's going to be helpful because hopefully there'll be much greater consciousness about the need to treat mental health issues at least as significantly as we do physical health issues.
I actually, Ron, it's a great point, and I actually work with a number of leaders who have been talking about integration of primary care and mental health and behavioral health, because it's just not realistic to say, well, go see a psychiatrist, for example, and psychologists, licensed clinical social workers in mental health. I mean, there's such an amazing amount of health professionals where we can really learn from each other, but we've got to get over some real practical hurdles. If I want to ask a colleague of mine in mental health to see my patient the same day, we get into issues of being able to be reimbursed for that visit, and we start to identify a lot of barriers when at the end of the day, Ron, you're absolutely right. In fact, a number of issues related to readmissions for congestive heart failure have largely been tied to coexisting conditions like depression. So Jeannie Pinder, any insights on mental health that come from the work you've done over the years?
You know, I couldn't agree more with Ron, and that's one of the areas that we regard as something that is a challenge for us because it's such a widespread issue and it's so underserved at this point. And we do think that the Affordable Care Act holds great promise for rectifying that problem. I totally agree with Ron.
Thank you. And do you have an example? I think you might have some states that are doing some interesting work around mental health.
Yes. I'd like to give the example of Oregon, which is transforming its Medicaid program into delivery by coordinated care organizations. And these coordinated care organizations are not just for physical health. They are explicitly needing to integrate mental and behavioral health, and they're going to be held accountable for meeting a budget. So they're not only going to integrate, but they are intended to have a more effective delivery and a more cost-effective delivery. And in fact, in the program that I just mentioned, hopefully Oregon will soon bring its state employees into, and private sector employers to follow along. So that's very exciting.
Great. So Jeannie Stamper, I'm going to ask you, I'm actually going to answer part of this and then see if you've got some insights. George Margulis on TEDMED.com asked, what can we do to help reduce the cost of doing business for healthcare providers, and can those savings be passed to patients? And I'll just say, in the primary care practice I work in, we still deal with a lot of time and energy that goes into the administrative flow of medicine. We have a lot of different insurance companies that require us to report on different quality measures. I have about 6 insurance companies that ask me to do 6 different sets of measure reporting, and that takes up staff time, takes my time, and often I've seen that take a lot of the cost in healthcare in terms of productivity, as well as the actual dollars to staff the clinic, to do the reporting, etc. Have you seen any insights or examples in how we can reduce some of those burdens of actually doing the business of healthcare, and maybe any examples or insights into how we can pass that along to people like you and me when we're patients?
Well, certainly that's an issue that's been discussed for a long time, just the administrative overhead and the meaningful loss. Clearly technology plays a role in trying to introduce some efficiencies. There's a lot of work around creating platforms for collaboration and stable, secure information repositories so that the efficiencies of the actual delivery of care can be improved, where patients can have access to information, participate in decisions, communicating. You know, a lot of physicians are enabling dialogue with their patients via email, etc. So technology inside provider practices is important, and lots of work in this area is happening now. Culturally, it's a big impact to the offices as well, and so providers really need to spend some time working with their staff in terms of, you know, really embracing what the efficiencies technology can bring, and being creative in ways to leverage technology to get rid of some of the overhead that you mentioned around all these different disparate reporting you have to do for the variety of payers. Now, how do you actually translate that into cost savings? You know, I think that we're going to see in the whole area of healthcare reform, a lot of things have to play out. You know, we're seeing physicians, not take Medicare because of the reduced payment, and changing to concierge type practices because they think that's going to be better for them to serve their patients and to protect their income if they don't have to worry about all the rules and regulations and reporting, etc. So I think it's going to play out in time. I think technology is going to provide some opportunities to reduce costs and help pass it on. But I think the jury's out on, how fast we can make it happen and what all those unintended consequences are going to be, and how we're going to work through those.
Kavita, I just want to mention, I think this is also a significant challenge for the insurance community. We've got so many different plans, and it's not going to change enormously in the years ahead. And so it means that providers, when they are billing, they've got to fill out so many different codes that are different from one plan to the other, and as a result, we spend a lot of money on administrative overhead, and And so we do need administrative simplification. I'll tell you an interesting story. A few years ago, a friend of mine wrote a book about the Canadian healthcare system, and it wasn't for the purpose of promoting a single payer system. I think it's unlikely, at least in the near future or even the long-term future, that we'll have a single payer system here in the country. But you know, when he came back and had finished his research, I said, what was the most significant thing that impressed upon you about the difference that you saw when you were in Canada and the United States? And he responded in a way that I did not anticipate. And he said, the billing departments at hospitals. The billing department in a hospital in Canada is like a closet. The hospitals in the United States, you know, obviously they are huge offices and they got lots of staff people because they have to fill out many different forms with many different codes. And he said it was just extraordinary seeing the differences. And so since we're going to have multiple payers, it's now, I think, behooves the insurance industry to work together in such a way that we simplify the kind of reporting that's needed for providers when they seek payment for the services they're providing.
All right, thank you. So let's actually shift. You brought it up, Ron. It's my favorite topic, Canada and other countries. And why is it just so darn expensive in the United States? When we look at any of the other OECD countries, you can always bet that the United States kind of outpaces the others in terms of spending. And it is clear that when you look at quality, infant mortality, even other statistics, that we're not the best. And so I wanted to see if any of you have some insights as we come into our last minutes of this Great Challenge talk. Any insights into why it's just so darn expensive in the United States?
I have a thought. I think it's actually a great segue from what Ron was talking about, and the most recent question. Because the incentives for everybody in the system are so misaligned, all the players are working at cross purposes, and we pay extra for that. We pay lots of extra for providers and payers, that's doctors and insurance companies, to argue with each other, for patient providers to argue with both of those parties, device makers, big pharma, the pharmacy itself that dispenses the medications. All of the incentives are completely misaligned. And I think that's one of the big problems at the heart of the system. I don't know how we address it. I share the thought that single payer is not coming soon, but I do think that's one of the causes.
Well, and if I could add, many payers are recognizing that as payment models will change, ACOs are an example of that they need to change from, you know, just underwriting risk to helping manage populations and partnering with providers for a common goal.
Chapin?
So I've spent a lot of time pondering this question. Why is the U.S. so different from every other country?
I figured you did.
And let me think. So I think it goes back to the founding days of our country, when the structure of our government was built around limiting the powers of government and making inaction the default, and making it structurally difficult to pass legislation by having two houses and having the president have the authority to veto. And I think that by limiting the and also by setting up federal and state kind of divided jurisdictions, I think by limiting the power of the federal government, we set ourselves up to make it more difficult to kind of comb out the inefficiencies in all of our systems that are going on. I think it really shows up in healthcare because in most countries the national government sets the prices for all the various healthcare services and sets them at a much lower level than we pay in the U.S. And the government acts as the one big insurer, and there are huge economies of scale. Okay, if let's contrast the U.S. maybe with I think the U.K. is a good example. If we had the U.K.'s political system in 2010, Nancy Pelosi would have been prime minister. The House of Representatives would have been the House of Commons.
I love it.
And I'm not editorializing one way or the other whether it would have been good or bad, but what we would have gotten is an Affordable Care Act with a public option. That was the House version.
That's right.
Because of having to pass it in the Senate, and mind you, pass it among Democrats in the Senate, the public option was stripped out. Okay, if the House version with the public option had gone through, we would have lower prices. We would have fewer competing insurers. We would have lower healthcare spending, and that's kind of the most direct example I can think of where the structure of our political system kind of enables blockage of legislation that will smooth out, comb out the inefficiencies, and makes it more plausible for groups to protect their own interests by blocking things at all the different blockage points.
Great, thank you so much. All right, we're getting to, I'm going to get all of our panelists engaged with a fire round of a final question. And I'm going to say it, and then I'm going to answer it just so each of you have a chance to think about it. I want each of you to just give us a brief example of something that you've witnessed that's helping to really reduce cost. And you've already mentioned some of them, so if it's a repeat, that's okay. But I want all of our listeners / viewers / tweeters to have one example that they can walk away with so that we understand how the country is tackling cost. I'll start. One effort that we haven't talked about yet, the American Board of Internal Medicine Foundation has sponsored a campaign called Choosing Wisely. ChoosingWisely.org, I believe, is the website. Over 20 medical professional societies came forward with their top 5 lists each of something that we should not be doing in the medical profession. So 5 things that are very easily accessible. Consumers Report has actually done a companion way for patients to take that information. That's helping to reduce cost. And I'll pick on Ron because I always do. Ron, can you give us your favorite example?
Well, I don't like giving one. So I'd say I would say we need transparency in pricing. We need to have greater proliferation of what works and doesn't work from a clinical standpoint and from a value standpoint. And we've got to reduce cost shifting in our country. And I think we are going to do that considerably as a result of the Affordable Care Act, so we don't have so many different classifications of people who do and don't have meaningful care coverage.
Thank you. Jeannie Stamper. Go ahead and unmute yourself, Jeannie, if you're talking.
We need to focus more on wellness to prevent the chronic and catastrophic illnesses that are so costly. And part of that is through patient engagement, patient education, patient responsibility, and the provider community to facilitate that.
Perfect. Thank you. Jeannie Pinder.
I think the thing that we've all been talking about here is the democratization of information. Cost information, treatment information, payer information. And that's where technology is really going to get us there. I think power to the people, give people information and let them make choices and let them do the right thing.
Great example. Anne.
So building off of Chapin's description of our federal government, I would say that now we are where we are, and we therefore, and we still do not yet know all of the right answers. So states are a really critical place where they can put on their hat as convener of all the players, as purchaser, as purveyor of the public good, and of course they run the Medicaid program, and they are bringing the parties together to put the policy changes in place that will promote new delivery system and payment reform implementation. And I think that is another awesome piece of the puzzle.
Wonderful. Thank you. Chapin, last but not least.
So under the Affordable Care Act, the Medicare is going to start paying for bundles of care or episodes of care where they pay the hospital a fixed amount. Whatever post-acute care people will get is going to have to be covered under that one bundle of payment. That basic idea worked with dramatic effect to slow spending growth for hospital care, broadening that concept to other services in Medicare and beyond Medicare is, I think, where there's all of the promise in slowing healthcare spending.
Absolutely wonderful. Thank you for a virtual round of applause for our amazing panel. And I want to encourage people to continue to go to TEDMED.com and participate in the great challenges and the dialogue for what we know is going to be a hot topic for a long time. Thank you very much.
Thank you.